There's no question that novel targeted agents have shaped the role of the management in patients diagnosed with a CLL condition. Several investigators and we had learned that there was an outcome difference and there's still survival disadvantages in patients of different ethnic backgrounds, including Hispanics and African-American descent. So we looked at the Flatiron database, which is kind of like a large database throughout the United States. And we looked at the outcomes of about 4,000 patients, a little bit more. And it was representative of what we would see in the United States. About 83% of the patients were white, 8% were African-American, and the rest were Hispanics or other. And we looked at what these patients had received for frontline therapy and identified socioeconomic measures that may affect the choosing of the therapy that they were going to receive. And so what we found was that overall, only a third of the patients actually had mutation analysis testing to identify those characteristics that would tell us that the disease is more aggressive, such as deletion 17p, 11q, like all those tests were only done in a third of the patients. And when they were done mostly on patients that were Caucasian compared to African-American and Hispanics. So first, it was the definition of the characteristics of the patient. It clearly showed that it wasn't done throughout on all the patients as we usually recommend. We always want our patients to know what prognostic markers they have to identify what's the best therapy for them. So that was the first step. The second step was, if they get therapy, what are the therapies that they are getting? And what we identified was that patients that had African-American ancestry or Hispanic, they did not get the preferred novel targeted agent. As we all know, ibrutinib, which is the first-in-class covalent BTK inhibitor, has fallen out of favor due to potential toxicities associated with the use of the drug, such as cardiac events, bleeding events, etc. So the NCCN guidelines recommend preferred second-line, second-generation BTK inhibitors, such as acalabrutinib or zanubrutinib. So we look into who were treated with the preferred second-generation BTK covalent inhibitors. And we also found out that African Americans and Hispanics also received either chemoimmunotherapy or ibrutinib instead of the novel preferred agent. And then we looked into what was driving this. And unfortunately, what we found out was that it was driven by racial segregation. The majority of the patients were lacking internet access. They also had no access to a car or transportation, or they did not have medical care. So it boiled down to not only race, but also socioeconomic determinants of health. And it kind of like showed us that it's not only biology, but it's also your zip code, you know? And it's unfortunate, but it's important to understand this so that we can also correlate with the outcomes of the patients, because if you are getting a drug that is not as well tolerated or as efficacious, you may not do as good in terms of outcomes, and we should aim to change this so that all our patients have equal access to the best therapies available for them.